bilirubin concentrations decrease and any elevation should be elevated, and GGT being the most important marker of cholestasis, to emphasize again. And they also mentioned that liver disease which are unique to pregnancy are more commonly seen in pregnancy rather than any coexistent or exacerbation of pre-existing liver diseases. Coming to the last slide on imaging and endoscopy in pregnancy, I've gone one step further and included endoscopy also. So there are certain consensus statements on imaging in pregnancy. So ultrasound examination is extremely safe in pregnancy. We often do the examination of the uterus in pregnancy, but one may extend it to the liver or the upper abdomen if one is suspecting some hepatic involvement or liver disease in pregnancy, or there is an alteration in the liver function test, typically to look for fatty liver, any intrahepatic biliary radical dilatation, any gallbladder distension or wall thickness or pericholecystic fluid, etc., or presence of gallstones or sludge. Then regarding MRI, MRI again is non-ionizing radiation and it is considered safe in pregnancy. The only caveat being that the gadolinium contrast, the use of this should be limited and it is used in very specific conditions. Not all MRIs are done with contrast, so MRI otherwise seems safe in pregnancy. MRCP, which we do for assessment of biliary tract diseases, is generally safe. It is basically T2 weighted MRI images, which are without contrast and they are safe in pregnancy. Feeding should not be interrupted during pregnancy. There's a statement that if at all CT is extremely necessary for a diagnosis of a particular condition, one may still go ahead, but using the low radiation protocol with 2 to 5 rads. That is the recommended radiation in case it is absolutely necessary. There are also certain guidelines or statements on use endoscopy in pregnancy, and that diagnostic endoscopy, whenever there is a strong indication, is safe and it can be done like all surgeries. Everything can be done in second trimester of pregnancy. Uh, then the sedation for the endoscopic procedures, it is suggested that instead of midazolam, propofol is the preferred anesthetic agent. And regarding ERCP, since it involves the use of fluoroscopy or fluoroscopic radiation, one suggests that one may adopt for non-fluoroscopic techniques such as minimal use of radiation or using a lead apron to cover the lower abdomen of the patient during the procedure. Whenever electrocautery is required, bipolar electrocautery is suggested because in monopolar electrocautery, there's a risk of flow of electric current through the amniotic fluid and it can lead to complications. However, I need to emphasize this that all our ERCP accessories, they are all monopolar. So bipolar is a very specific device used in very specific procedures, which are generally not done in pregnancy. And lastly, it should be in the lateral position during and after the procedure, uh, during an endoscopy. So this was a short summary of how one may approach to liver function test reports in pregnancy, what all questions one may think of in terms of history and examination while approaching a patient with altered liver function test in pregnancy. To understand the normal and abnormal test, one needs to know that how they get affected during the different trimesters of pregnancy and whether any further evaluation is actually essential. I have not included the diseases of pregnancy related liver disease in the current discussion because I have gone through the webinar episodes and I think each and every diseases will be discussed in detail in the subsequent webinars. So I think I'll hand it over to Madam for the next further two sessions on the two diseases that we'll be discussing today, hyperemesis gravidarum and intrahepatic cholestasis of pregnancy. Thank you.
Yeah, you can put your queries in the chat box. So Dr. Kranti will moderate it later at the end of the session. Or you can now, Dr. Kranti, you can moderate it for this particular session also now.
Yeah, I have just typed in the chat box. Thank you, Dr. Rohan. It was a very elaborate and very crisp, and you've covered major points and enlightened us on many new things also. We'll be on the lookout for questions. In the meantime, should we proceed with the next case presentation?
Yeah, I think we can start with the case presentations.
I'm sharing my slide screen. Is it visible? Is it seen?
Yes, yes, yes.
Thank you so much. I'm very sorry for the internet glitches. Welcoming you all to the first webinar series of 2026. And on behalf of Navi Mumbai Gynec Society, I thank the president for giving an opportunity for all of us to see this and attend this at a comfort level by expert panelists we have today. Dr. Rohan Yole sir has already been very instrumental in covering up and made up for the loss that we had, the time loss also. And he will be guiding us upon the next case, which is hyperemesis gravidarum management tips. The case will be presented by postgraduate resident of Navi Mumbai. One is Dr. Leena will be presenting this hyperemesis gravidarum case. Another Dr. Gayatri from Apollo Hospital will be presenting the next case. And Dr. Deepak Kumar Gupta sir and Surekha Mudhe ma'am are the experts who will be guiding us. Sorry sir for the introduction, I was very late.
No, Kranti, I think you should increase the volume. You are not so well audible.
Okay. Now?
Better.
Okay, thank you. Dr. Leena, can you unmute yourself and present this case?
Yes, ma'am. Am I audible?
Yes, you are audible.
A very good evening to everyone. Myself, Dr. Leena Dhande, first year PG resident from PGIMS Navi Mumbai, presenting the case of hyperemesis gravidarum. Shall I start, ma'am?
Yes.
Presenting the case of 21-year-old Mrs. SS primigravida with 2 months of pregnancy came to the OPD with the chief complaints of excessive vomiting since 2 weeks, unable to tolerate orals since 7 days, generalized weakness since 7 days, and there is a history of weight loss and loss of appetite. There is no history of eating outside food, no any history of fever, abdominal pain, diarrhea, jaundice, headache, visual disturbances or altered sensorium. No history of bleeding per vaginum, lower abdominal pain or swelling over the body. Menstrual history. Her last menstrual period was on 23rd of November 2025. He started menarche at 13 years of age. Her past cycles were regular and normal. Her estimate date of delivery is 30th of August 2026. Obstetric history. Patient is married since 1 year. It was non-consanguineous marriage, primigravida, and it was spontaneous conception. Past history. There is no any history of diabetes mellitus, thyroid disorder, any high BP, psychiatric illness, asthma, tuberculosis or epilepsy history. There is no any history of medical or surgical interventions in the past. Family history. No family history of diabetes, thyroid disorder or multiple pregnancy. On examination, patient is conscious, cooperative and well oriented to time, place and person. Patient's weight is 44 kgs, lost 1 kg in 2 months. Tongue is moist, decreased skin turgor. Pulse is 90 beats per minute, regular and low volume. Blood pressure is 90 by 60 millimeters of mercury. Febrile. No pallor, icterus, cyanosis, clubbing or pedal edema. No generalized lymphadenopathy or no neck swellings.
So is this a case of nausea, vomiting and pregnancy exaggerated form or is it hyperemesis gravidarum? We would like our expert Dr. Rohan sir to guide and Dr. Surekha Mudhe ma'am to intervene whether it is any of these three. Over to you, sir. Dr. Rohan sir, are you there?
Yeah, sorry, I couldn't hear the question.
This case, is it an exaggerated nausea, vomiting in pregnancy, or is it hyperemesis gravidarum per se? Because she said the tongue is moist, 44 kg, she has just lost
Right.
1 kg. And yeah,
Yeah.
this is commonly
So,
what we
so
encounter.
So there are, yeah. So whatever you call it, exaggerated nausea, vomiting, or hyperemesis gravidarum, that these are all theoretical terminologies, we believe. But the hyperemesis gravidarum, I think it has certain definitions that there should be excess vomiting more than 3 times a day before the 22nd week of gestation, with or without. There should be more than at least 5% loss of body weight as compared to pre-pregnant weight. So in this case, if I'm not wrong, there's 1 kg body weight loss, right?
Yes, yes.
Yeah. But there are signs of dehydration, and there is because there is loss of skin turgor. I remember reading in one of the slides. Yeah. So it is more
Is there
likely not
also
exaggerated nausea and vomiting of pregnancy if you go strictly by the definitions. But there is no uniform international diagnostic criteria. There are some well cited criteria which I just quoted, that more than 5% body weight loss and presence of metabolic
More than
metabolic and
5% of pre-pregnancy
pre-pregnant weight loss.
pre-pregnancy
Yes,
weight
yes,
loss, and
yes.
secondly electrolyte imbalance.
Electrolyte imbalance, correct.
So whether she was tested for that, for the electrolyte
Yeah. So before that, it
you
is
haven't
difficult to
completed
comment
it?
on that.
So, ma'am, would you like to admit this patient and evaluate, or would you start something on an OPD basis first?
No, we can start with the OPD basis. Admission is not really required if she manages to control her nausea, vomiting with routine, H1 histamine receptors blockers, and routine the drugs which we give, even ondansetron. If nothing is, and if she's critically, the electrolyte imbalance is very bad, and if she's critically dehydrated, then we would like to admit her and start with IV fluids and replenish with IV fluids.
Yes.
Agree completely with madam.
Is there any new scoring system that we are not aware of?
Pyridoxine, by the way, has no role, which all our antiemetic drugs contain pyridoxine and doxylamine. But I don't think there is any role of pyridoxine.
Yeah, it is more of the doxylamine, which is the H1
It is more
antagonist,
of a doxylamine.
antihistaminic.
Yes, yes,
Yes.
yes.
So that is the one which act.
Doxylamine succinate. And in case the patient does not respond to that, then we have the second line coming up. Is there any new scoring system we are not aware about, sir?
So I'm aware of this modified pregnancy unique quantification of emesis and nausea, the PUke score, which has certain parameters such as nausea, stomach pain, vomiting, and dry heaves, and they're again categorized into 4 categories based on the frequency of these symptoms. So the PUke score is maybe used to classify the severity, whether it is mild, moderate, and severe. And based on that one it may help in guiding whether to admit the patient or not. But again, ultimately, it's a clinic. Very important thing is whether the patient is able to tolerate orally. If she has persistent vomiting despite the oral feeds, and then that may be a reason for hospitalization.
Right. So we have seen nausea, vomiting, retching, and then the score in case it is more than 13, then we have to, but it's still as such that we don't go into the practical scoring. But what if it is correlating with weight loss, dehydration? Surely we would be admitting her and giving her something known as daycare ambulation also. Is there ambulatory daycare therapy that we are aware about? Maybe we come to it later. So can you enlighten us about idiopathogenesis? Is there any genetic basis, or how can we prevent in case there is previous history, something like that? Is it just in the books?
So I'm not sure about the gut microbiome, but there are associations with H. pylori infection and hyperemesis gravidarum. I'm not too much aware about the genetic basis, but yeah, it is related to the hormones or the beta HCG, which is an important factor. Etiopathogenesis factor for the development of hyperemesis gravidarum, and that typically occurs because there is delayed gastric emptying, more gastric stasis, and the relaxation of the lower esophageal sphincter, and that causes repeated vomiting. And
That also
then there are
correlates with
certain,
yeah,
sorry.
that also correlates with high vomiting in vesicular mode or twin gestation.
No, multiple pregnancies, molar
Multiple,
pregnancies.
yes. So there are multiple risk factors such as multiple pregnancies. In a primigravida patient, it is seen more in the first trimester, whereas in a multigravida, it may be seen a little later in the second trimester of pregnancy.
So we got to know that it does
Things
have
like
a
female fetus.
hormonal
Yeah.
hormonal association. It does have H. pylori association.
Yes.
And what about
Yeah.
somatic? Have you
Yes.
experienced
So
this?
the patient does have, if the patient has some previous history of any psychiatric illness and all, there is definitely a higher risk for developing hyperemesis gravidarum.
Then what constitutes evidence-based first-line therapy for hyperemesis?
So, evidence-based therapy, firstly, would be to give dietary and lifestyle modification. The dietary modification will be in the form of small, frequent meals instead of large meals at one time. That the reason being the gastric volume increases and the gastric emptying is delayed. So you treat that first. Then the second part would be to avoid any specific triggers which cause these symptoms. So then there are other evidences of the use of ginger, which again is quite controversial, whether that really helps in, but in the US and all, they do use ginger supplements, also tablets to treat hyperemesis
Everything is in
gravidarum.
moderation.
Yeah.
That is the key.
Right. And then there are other things such as acupressure over the pericardium, and there are certain other modalities which are mentioned in papers. Again, all theoretical, whatever the patient best. So you start in a stepwise manner. You first start with dietary modification. You counsel the patient. You look for any signs of dehydration or metabolic imbalance. If they are present, you admit. Otherwise, you try to treat on an outpatient basis based on these and give some safe medical supplements such as doxylamine, succinate, 25 milligram. Again, pyridoxine and all. It's more of a supplementation, vitamin supplementation. You also give thiamine to prevent Wernicke's encephalopathy in case there is severe dehydration. You give electrolytes in the form of Ringer's lactate and IV fluids and electrolytes. And
When we admit the patient, which IV fluid would we prefer? Ringer's lactate and normal saline?
so Ringer's lactate is the most physiological IV fluid, and that would be the IV fluid of choice for any dehydration and hyperemesis gravidarum.
Would be
Or
advise
dextrose.
thiamine.
Would
dextrose.
generally avoid dextrose, yes.
You said about thiamine, so can you enlighten about thiamine, or should we first refer to you only, then maybe you take a call?
No, so thiamine supplementation regularly, it does not have any disadvantage. So one may directly start with thiamine supplementation, 100 milligram IV injections. And this is because it helps in prevention. And before giving dextrose, definitely thiamine should be given. And it does prevent in the development.
What is the role of proton pump inhibitors?
Yes, so proton pump inhibitors such as pantoprazole or esomeprazole, they can be given. They are considered category B drugs in pregnancy, and the safety is well documented. And I don't think we are still hesitant in this current era of using PPIs in pregnancy. So ondansetron or any antihistaminics, 5-HT4 antagonist, 5-HT3 antagonist, sorry, and proton pump inhibitors can definitely be given for symptomatic care. Yes.
So this is what in nutshell, the first line pharmacotherapy, the second line, and metoclopramide. What are some concerns about metoclopramide? Why are we hesitant still, and we still prefer ondansetron, whereas the gastroenterologist would prefer metoclopramide?
So metoclopramide is definitely safe. There are, if it is used excessively and in elderly, it does cause extrapyramidal side effects. But for acute symptoms and for short duration use, we use it regularly for most of our patients, and it is safe. So metoclopramide does help in hyperemesis gravidarum. And ondansetron, on the other hand, it's an antihistaminic, so it helps. It acts on the different pathways. So both help together for the nausea and vomiting of pregnancy.
So both are supposed to be added on at the time of discharge when patient is.
Yes. So the least possible tolerated dose, whatever is required to curb the symptoms, is can be given.
So can you talk about
Any
refractory?
incidents of oculogyri crisis with clopramide?
I have not
Metoclopramide?
encountered any such case, but ma'am, you might be like better able to tell
No,
us
we
about
don't
it.
give in pregnancy. I have never given metoclopramide in
Yeah,
pregnancy.
ma'am, I have had very good results also with this metoclopramide. Sometimes ondansetron, like there are incidences of cardiac defects and all those were there, but still we use it, though some series studies have shown. But metoclopramide has given wonderful results, but I have had extrapyramidal symptoms also in one of patients. So that is what we should tell them, ki like you can expect some tremors or shivering, then you report immediately. Then we'll have to
Or
stop.
those orofacial dyskinesias, which are quite common with metoclopramide.
Yeah.
Again and again, you have to go back to the dietary focus and then counsel, because these are add-on therapies and they should be given in supplementation to the diet, which is often forgotten by the patient once he starts getting cured of the vomiting. And what is this third line pharmacotherapy, sir? Which I have just heard from Bindu ma'am. She has treated a patient with corticosteroids in refractory cases. So can you enlighten us about that?
So they should be avoided as much as possible, as far as I understand, corticosteroids in pregnancy, in early pregnancy.
So that is in case
Or
See, Dr. Kranti, Dr. Deepak is also here on the line. He has treated my patients. Can you enlighten us, Dr. Deepak? Dr. Deepak
please
Kumar
help us
Gupta.
to the. I have not yet
corticosteroids as has a role in hyperemesis gravidarum or
Yes,
in
yes.
RCH.
Yes, we have given.
Intrahepatic. I see.
refractory vomiting in case when patient is getting so deteriorated to save the
Am I
life of the
audible?
mother and
Hmm.
want to continue.
Yes, you are audible.
So what
Grant,
happens if you
speak
have
a
a
little louder,
persistent
please.
vomiting which is not responding to your routine medications? You have tried your dietary modifications, you have tried your ondansetron. We have gone to methylpred also in some of our cases on that point of view. You use high dose of phenergan, chlorpromazine, promethazine. These are something which you use as a backup support. Methylpred also works nicely in certain patients. You can give orally also, you can give IV also. If he's not taking orally, it doesn't seize inside the stomach, you give him IV. But again, this has to be given for short duration, not for long duration. And whatever side effects because of methylprednisolone were self-limiting. Now I'm aware because most of the steroids side effects are there, but again we are given it for 3 days or at the most 1 week, not beyond that point of view. So these are used for all refractory cases of vomiting which is not responding to your metoclopramide, ondansetron, or phenergan, which is being given routinely to our patients in that point of view. Coming to metoclopramide, we are all worried about extrapyramidal side effects. But trust me, those extrapyramidal side effects can be managed much more easier than anything else. If you can control the vomiting of the patient with those medicines, the percentage what we have been given in books are around 8 to 10%. But trust me, when we use it, it's hardly seen in less than 2% of our patients. And we can manage those extrapyramidal side effects with simple injection of Avil and phenergan, water we can use in that point of view.
Over to Mude ma'am. Can you enlighten?
Yeah, I think I already told about pyridoxine. No use. Yeah.
Is there a role of diazepam or anti-anxiety?
Anti-anxiety. Yeah, sometimes we may have to give this if she is really, psychologically imbalanced. But many times counseling helps.
Yeah, counseling does help. And corticosteroids in refractory
Yes.
cases help. And what about termination of pregnancy?
In my whole so many years of practice, I think I had only one patient who insisted on termination because of severe vomiting, and I did it. I mean, because she was so insistent, and of course, she had one live child, so there was no issue as such. And she was so fed up of this vomiting, and nothing was really helping her. So
Unfortunately,
that is when. One thing I wanted to add, Dr. Rohan, was, basically we all should try to palpate the liver clinically rather than, rushing over to the investigations. Normally in pregnancy, the liver is always pushed up and posteriorly. So if you feel the liver in a pregnant woman, that is not normal. So that is a basic thing which we all should remember. And secondly, I think the dose of bile acids, which you said that more than 40 millimoles per ml is pathological, but that really does not really critically call for an action to terminate the pregnancy or to go for a premature delivery, which will again call for, other complications of prematurity. The recent studies say that more than 100 millimoles per ml of bile acids should be, considered as critical, and then we think about termination of pregnancy.
Yeah, ma'am, we are coming to the next case
Yeah.
regarding.
Ma'am, Bindu ma'am has tried ambulatory daycare therapy.
Kranti, thoda louder, please.
Ambulatory daycare therapy, is this okay?
Yeah.
I have to literally put my laptop to my ear. Guess
Okay.
I'm getting old.
So, yeah, what Dr. Kranti is telling, see, is there some patients when we say we need to admit you, they are little bit very hesitant and most of them would not like admission. So, is there any role for ambulatory daycare? It is just putting the IV fluids and then giving some injectables, antiemetics. So, what is your take on that? That's what she wanted to ask.
Actually, that also gives some sense of satisfaction to the patient sometimes.
Yeah, of course. I mean, ambulatory daycare we can try. But termination is not really the solution. That's the last resort. I told you that only one case I had to do the termination. I don't know what is the view of Dr. Deepak regarding the ambulatory care.
I've not dealt with such patients, but I don't think so. I have heard from at least whatever experience I've done, from whatever gynecologists I've met together, what manage this patient. We have never terminated till now. Whatever we have tried to manage with going upfront without worrying of the side effects. We can go to higher medications. Now it is beyond that point of view. Keeping the patient nil by mouth sometimes also works sometimes nicely. We have seen some patient keeping completely nil by mouth on IV hydration only for a few days. That's also we have done in some of the cases.
A patient with psychosomatic illness, when she refused to continue the pregnancy, a lot of fear, and we tried our level best. We involved the psychological counselor also. She was so much obsessed with the pain part that she had to take epidural analgesia for the second trimester abortion, and she landed up with Roux and White. So probably some gastric problem is added on with somatic illness. So this was a terror, like nightmare of pregnancy in hyperemesis. This was a case that I witnessed.
Yeah. See, Dr. Deepak and myself had recently treated with corticosteroid. She is doing well. She is now 24 weeks of pregnancy. Now she is very happy. I think Rohan, you have also seen that patient. Yeah, she is fantastic. We give as Dr. Deepak was saying, methylprednisolone we had given, and she did well finally with that. Even Dr. Deepak had given granisetron. So I said no, we will. I just ondansetron is. Okay, enough. Yeah.
What was the dosage given?
Yeah, Dr. Deepak.
Granisetron.
For the granisetron?
No, the dose of prednisolone, what was the dosage you had given?
Normally it's a 6 mg dose. We give it, start with 6 mg dose to start with OD. That's one single dose is quite good enough.
Single dose OD?
Yes, start with single dose OD. If you want, you can make it to, but single dose works nicely most of the patients.
Oh, okay.
You can increase to at least go to up till 3 times a day also.
Oh.
Great, sir. So, just the new learning of today, we summarize. Hyperemesis gravidarum is excessive vomiting less than 20 weeks of gestation with or without metabolic disturbances like carbohydrate depletion, dehydration, and disturbed electrolyte or electrolyte imbalance. This lesser than that is called exaggerated nausea vomiting. So the diagnostic criteria include persistent vomiting with dehydration signs and weight loss as said more than 5% of pre-pregnancy weight. The incidence of nausea vomiting in pregnancy is largely 60%, whereas hyperemesis gravidarum is less than 2% worldwide. The risk factors being primary gravida, juvenile pregnancies, multifetal gestation, fetal anomalies, and patients who are already on antidepressants. So can we now have the moving on to the next part of the discussion, which is intrahepatic cholestasis and pregnancy. I formally invite Deepak Kumar sir, who has been an associate professor in St. G.S. Medical College, KEM Hospital, a senior consultant in Apollo Hospital. He has a lot of publications and poster presentations to his credit. And he headed the IBD clinic in 2010 in BMC. Presently, he is senior consultant at Apollo Hospital with special interest in hepatobiliary diseases, advanced endoscopy and bariatric endoscopy, and a very dear friend's husband. So I happen to knowing him very personally. Thank you, sir. Welcome to this seminar.
Yeah,
He also
before
does-
we start the next session, somebody had a question on meclizine, use of meclizine for hyperemesis.
Any of you, Rohan sir or Deepak sir, any of you?
No, madam, I have not used meclizine for hyperemesis in the past. I don't have any, I mean, theoretical knowledge, yes, but no practical experience on using meclizine. Maybe
But
Deepak.
there are so many better. Yeah.
Neither I even I haven't used it.
Meclizine is also I've not used it. Is there any brand name? Because most of the time nowadays we are aware of brand names rather than the pharmacological name. I don't think so. I've used meclizine anyway till now.
What I have heard of meclizine is probably during the travel and
Yes,
motion sickness.
for motion sickness. Probably
Motion
Avomine
sickness.
is the trade name. I don't know.
So we
Yeah,
use
yeah.
Flunarizine is there, which we have for travel sickness. You can
For
use as
motion
a counterpart. If it's an antihistaminic, you can use it. That is what I can say. If it's an antihistaminic version that you can use. Cinnarizine is one which we use for motion sickness, quite common. Stemetil, which we commonly use.
So granisetron
Any of-
also works very well in cases where ondansetron has not given relief. So it is one of the rescue medicines. I don't know about pregnancy, probably.
No, I have used in pregnancy many times outside in Apollo also. It has worked nicely. When ondansetron doesn't work, we step on that point of view. Yes, there's some skeptical idea of using the 5-HT serotonin antagonist in some of the patients. But again, our aim is to give relief to the patient. That's what we always take a call. And always we are worried about the side effects. I just said side effects, whatever have been published, are still not seen so commonly in our practice, what we see.
Dr.
There are
Kranti
no-
will proceed to the next case after introducing Mude madam.
Yeah, thank you. Dr. Surekha Mule ma'am is a well-known and senior practicing consultant here. I have the pleasure of inviting her. She is the founder, member, and former president of NMOGS, a senior consultant at Mathadi, Sri Mukti Sangatna affiliation, and with special interest in high-risk pregnancy, cancer awareness, vaginal surgery. Welcome you, ma'am. Today we will be
Thank
having
you,
another
Kranti.
case. The next case will be presented by Dr. Gayatri Kulkarni, who is a postgraduate senior resident at Apollo Hospital under Dr. Bindu ma'am. Over to you, Dr. Gayatri. Have you joined?
Yes, ma'am. Good evening, all. Myself, Dr. Gayatri Kulkarni from Apollo Hospital. I am a secondary DNB resident at Apollo Hospital, Navi Mumbai. I am going to present here the case of intrahepatic cholestasis of pregnancy. So there was a female 28-year-old gravida to abortion 1 with 7 to 8 months of amenorrhea. She presented to us with at 25 weeks of gestation with complaining of itching on more on extremities. There was a previous history similar at 5 months of gestation. She took treatment for the same. We referred her to the gastroenterologist and we started her on ursodeoxycholic acid 300 milligram twice a day and cholestyramine 4 gram twice a day. But she didn't had relieved of symptoms with this medication. So we started her on S-adenosine methionine. There was no history of any skin infection. There was no history of fever. There was no history of any allergy to any medication or food. Patient was started on tablet ursodeoxycholic acid 300 milligram twice a day and tablet cholestyramine 4 milligram twice a day. Tablet S-adenosine methionine also added as patient was not relieved with the symptoms. Apart from these medications, itching not relieved. So, with the opinion of the gastroenterologist, we increased the ursodeoxycholic acid to 450 milligram twice a day from around 30 to 31 weeks of gestation. We have monitored her with LFTs and serum bile acid. Apart from that, rash was present, pruritus was present. These are the investigations which we have monitored. On 2nd of August, her first visit, SGOT and SGPT was 47 and 98, alkaline phosphatase was 221, and serum bile acids were 24.5. Then we monitored her weekly. On 9th of August, her SGOT was 77, SGPT was 295, alkaline phosphatase was 227. On 25th of August, SGOT was 111, SGPT was 244. On 5th of September, SGOT was 79 and SGPT was 218. Alkaline phosphatase was 276. Serum bile acid was 12.3. On 15th of September, SGOT was 64, SGPT was 143. Alkaline phosphatase was 260 and serum bile acid was 9.2. On 25th of September 2025, SGOT was 90, PT was 218, alkaline phosphatase was 292, and serum bile acid was 10.9. So, in spite of this large doses of medications, she didn't relieve of symptoms. She had refractory pruritus, and with
We have experts. Let us ask them how they manage. Thank you so much, Dr. Gayatri. Can we ask the panelists?
Just I want to
Dr.
add, we have terminated her at 34 weeks of gestation. In spite these low levels of bile acids because of the insistence of the patient, and the multidisciplinary discussion was done along with the gastroenterologist, and after giving the steroid drug, elective cesarean section was done on 6th of October at 34 weeks of gestation.
Okay, thank you so much. So was this a case of refractory pruritus or intrahepatic cholestasis, or was it only a skin dermatological infection of rash, urticarial papules? What do you think, Dr. Deepak?
So this case which has been brought is mainly a refractory pruritus which is going on. His bile acids once was 24.9. So as per the definition, it fits into anything which is more than 19 or 20 is called as IHC. But there should not be any skin lesions. If they have any skin lesions, you have to think of any underlying skin disorder. It could be some urticaria, it could be some pruritus prugo, whatever is there. We need to be very sure there should not be any skin lesion, because if you have intrahepatic cholestasis of pregnancy, the skin is normally smooth. You may have scratch marks at the most, but no skin lesions per se. So if you ask me if it fits into the diagnosis of intrahepatic cholestasis of pregnancy, as per a definition, more than 19, it fits because one of the level is around 24.5. But however, we all know that this bile acids doesn't correlate with the itching. So even if you target the bile acids, the itching may not subside. You can to use all the methods possible to reduce the itching, right from your cholestyramine if you require something else like antihistaminics. Even sometimes you can use, sometimes we have used rifampicin in some of my patients also. There's a small dose which we use 150 milligram to bring the itching down. These are something which has been used, but again, this has to be used with cautious because you have to understand you are playing with something liver also, which we all know rifampicin is known to have some liver function abnormalities when you start that point of view. So those things has to be taken into consideration. So whether the patient fits into this, I feel it's mainly intrahepatic cholestasis of pregnancy as per the definition fits into that point of view, but you have to be very sure there should not be any underlying skin disorder for the patient.
Isn't it that in intrahepatic cholestasis, we have more of a itching on palmar and on the soles and palms?
It is more in the extremities, but trust me, if the patient has itching in the night time, they itch completely on the back, much more worse than anything else. It starts on the extremities, difficult to say, but again, you have to understand it's more of in the nocturnal time, you will see them itching like people have seen, you have used combs, you have used all the methods to bring the itching down. We have seen in the back also lots of scratch marks coming to us. Yes, it starts on the extremities, which we say, but difficult to say it's a localized point. If you have itching, which could be due to many other causes beyond pregnancy also, you have a generalized itching. That's the reason we need to have a dermatological evaluation if it's there.
Deepak, can you keep your camera on? People want to see you. Dr. Deepak.
Sorry, I'm putting on a laptop. So my laptop is not showing the webcam connected to this thing. That's my limitation on that point of view. Sorry.
Okay.
The webcam is not working on my laptop. It's my second laptop which is not working. My first laptop is with my daughter who is giving the exam. Sorry.
Oh. So what about the liver function test? We saw that they were repeated. Whether all of them need to be repeated, or would you repeat only specific like alkaline phosphatase? Then we would get false positives or rising, and how much should we rely on them?
So when should we advise liver function test? Simple. If you have symptoms, you should start doing the liver function test. You have itching. Itching normally starts in the late second trimester, but it can come early second trimester also. If you have any symptoms pertaining to liver, in the form of anorexia, nausea, vomiting, which is there, even if you're suspecting hyperemesis gravidarum, I would still prefer a liver function test. So if you ask us if it's symptomatic, you should go ahead with the liver function test. If the patient are asymptomatic, we can wait and watch. That's what we always say. Full battery of liver function test, yes, it's always advisable to do a full battery of liver function test because each parameters are important, right? From bilirubin, SGOT-PT, bile acids, GGT, all these parameters discussed by Dr. Rohan in his slides. These always give us a hint or a clue whether the patient has an underlying liver disease or we're dealing with a pre-existing liver disease or it's something new which is there because of the pregnancy itself. How frequently should we repeat them if there are symptoms of pruritus? It's not the pruritus because pruritus doesn't matter. It doesn't matter with the levels of LFTs or bile acids. It's only thing the bile acids are giving, as I already said by Dr. Surekha, that anything which more than 100 is considered to be very significant. It's called severe IHC. You have to think of early delivery as early pregnancy or termination of pregnancy in your case. But again, if you want to do a serial investigation, we ideally do it in a patient who is doing every 7 days or 10 days, once a week is required, can be done. Most of our patients are done. If required, to just monitor that thing. If the bile acids are to be monitored, if you have to monitor liver function test, which is very high, whether it's responding to your oral medications or not, to have a serial monitoring gives you an idea. But again, that also is important because we also take the peak level of bile acids nowadays. We don't take any level. Anytime in the pregnancy, if the bile acids goes more than 40 or 100, these are significant for us, as the cutoff has been said. More than 100 is more significant. Anything which is around less than 40, we can take it as normal, mild one, and that's treated as a normal pregnancy. We just continue the pregnancy till the term is required.
Can I just interrupt? Dr. Deepak, I mean, the pruritus is the symptom which starts earlier, right? So by the time the biochemical changes take place, it takes a little time. I think it's about 8 to 9 weeks.
Ma'am, what happens sometimes we have seen without pruritus also liver function getting deranged. But what do we do in those cases? Is the patient not symptomatic? Do we want to treat the patient with some medicines which has very less, which has effect only on reducing the pruritus, and sometimes the level can bring down some biochemical improvement might happen, but it may not bring out to normal. So if you have symptoms, then you can go and evaluate.
And in fact, there is a case reported where the intrahepatic cholestasis started as early as the 10th week of pregnancy.
And we have seen at 8 weeks also.
Oh.
That's why KM has a wonderful, lots of cases. And that's the reason we have said, we have seen at 8 to 9 weeks, difficult to prove, but again, that was we have seen, but responded to that ursotic cholestasis, and the patient responded. Bile acid at that time was very high to start with. It has gone to 80, 90 when we have seen that patient. So we've seen from 8 to 10 weeks, even in the first trimester, we have to have a idea that ICP can come earlier. These are atypical presentation. Yes, rarely seen, but you have to be aware of that point of view also.
Yeah, can I ask one question? In that context, the patient comes so tech-savvy, Google, and they put in the ChatGPT, the values and all those, and they are worried about the outcomes of the baby. So they come to, as far as we were discussing, the values of bile acids are not important. So we can take it up to term. So how would we go ahead with counseling the patient, and how that your tests are being repeated, or how is it like, or symptomatic relief, or how will it be like, Dr. Deepak?
So as already said, look, even if you ask me in ICP, I have seen one fetal death in the whole thing. This was only rarely seen. That was seen in that patient. But again, there was some other condition with that thing. He has some thyrotoxicosis or something like that at that time that patient had. That was a complicated case. That's the reason we have seen that point of view. Now you have to explain to the patient, first of all, when you have ICP also, you have to understand that your rate of getting the perinatal outcome or morbidity is nearly same as the normal population. When you are suspecting a bile acids, this ICP, previously, if you have whatever literature was there, you have ICP mortality rate was around, fetal death was around 20 to 30%. But again, the recent literature has given around 3.5%, even in very high bile acids. Not in low bile acids, if you go less than 40, I think it's less than 1.2%, if I'm not wrong, which is equal to the normal population which we see. So we have to explain to them that, yes, it's a disease, it's a condition in pregnancy, part and parcel of your pregnancy. If you ask us nowadays, we're seeing more frequent ICP because of use of progesterone, IVF, and all those things, adding to the factors of that point of view, the bile acids goes up. So you have to explain to the patient, yes, you have a higher risk, as slightly higher risk, but again, it's nearly normal as the normal pregnancy. You should not go and bother on that point of view. Yes, there will be certain cutoffs which we will be follow. Your gynecologist will be the best person, the gastroenterologist or the hepatologist will be the best person to give you an idea when we want to terminate the pregnancy earlier, or if we want to give it or not point of view. Because whatever we do, bile acid level also gives us high fetal risk. But again, there's certain cutoff which we follow nowadays as per the, I think this is the guidelines from the RCOG guidelines also, if I'm not wrong. So as already said, anything which is more than 100 is quite alarming. That's where we have seen higher fetal death rate in these cases, stillbirth we call it. But again, less than 100, 40, 99, you can try to do it early, but again, not required in all the patients. Mild, you can complete till the term delivery.
Also, associated risk factors with gestational diabetes, preeclampsia, multiple pregnancy, and underlying liver disease, they will also make a difference.
So you have any other features like thyrotoxicosis,
Yes,
diabetes,
hyperthyroidism or
preeclampsia. These are additional factors adding to the pregnancy. So you have to think of those parameters. If this is maybe added to the bile acid level, if you may have a moderate level, but if you have these underlying factors, you may contemplate early pregnancy in such group of patients if you are suspecting.
So any difference in the fasting and non-fasting levels of bile acid?
If you ask us what's the best test to be done, non-fasting, because whatever bile acids tend to increase more after your meals. So if you do it in a fasting state, your bile acid may be on the lower side. So if you take a fasting bile acids, it's on the lower side. It may not pick up mild intrahepatic cholestasis of pregnancy. But again, whatever studies has been done till now, whatever levels have been given, if I'm not wrong, these are done on fasting state of bile acids. So if you ask us, any random bile acid level will do. Anything which goes more than 19, you have to evaluate. If it's less than 19, if you're still suspecting ICP in a patient who have pruritus going on, no skin lesion, then you can ask to do a postprandial bile acids. In such cases, you might have bile acids on the higher side and you can confirm your diagnosis of ICP.
Okay. So we have seen that sodium-oxycholic acid improves the pruritus symptomatic relief as well as the liver function test. Now, what are the other evidence-based options or alternative adjuncts we would suggest? Mude, ma'am?
Alternative therapies for the, you mean to say intrahepatic cholestasis, right?
Yeah, for itching, symptomatic relief, we would give.
Symptomatic relief. Okay. So a local application of calamine also sometimes helps, especially if you keep it in the fridge and, you know, a cold application, it helps. As he has already said, cholestyramine sometimes helps, but I have never tried it in my practice. Antihistaminics in very severe cases, and rifampicin, of course, I have not tried. Injection vitamin K, I have no idea about this because I have not tried this. But a local application and antihistaminics I have tried and they work well.
Yeah, I think gynecologists would first give antihistamines and local applications for soothing the burning sensation they have while itching, and then over to the gastroenterologist for the rest of the treatment. So,
No, I have a comment to make on vitamin K. Patients with ICP are more prone for with liver function abnormalities are more prone for postpartum hemorrhage and all those stuff. So that is why vitamin K is advised in very severe cases, so that that part is also taken out. Dr.
Not
Deepak,
per se for itching. It is
Yeah.
to prevent a PPH.
yes, Dr. Deepak.
even in health syndrome,
So what I can suggest from my point of view, if you have a cholestasis, which is a long-standing cholestasis, look, when we say any vitamin K deficiency to happen, you have to have a cholestasis which should be at least more than 3 to 4 weeks. So if you have a chronic cholestasis, the patient has come to you at least 28 weeks, then you can think of giving vitamin K just to prevent the hemorrhage component. Because you have to understand, when you have chronic cholestasis, your vitamin K goes low and your INR can jump up.
So
In
what
such-
about oral? Is it oral vitamin K? Oral, I don't think it's available here because textbooks say about oral vitamin K.
The oral vitamin K also is available. The brand name is called Kenadion, which is
Kenadion.
available with us.
So how do we give that? And what?
The only efficacy is the bioavailability of the oral medication. We are not sure about the bioavailability of the vitamin K oral, because even if we take orally, how much is going to absorb, nobody can predict on that point of view. So if you have any doubt, use injectable, either IV, either intramuscular, whatever you want to use it intravenous or intramuscular. Oral, if you want to use, it's available, but I am not available. The bioavailability of oral vitamin K is not so good as injectable. So if you want to use injectable, that's what I always say. But again, if you want to use Canadione, is also a tablet which is available in 10 mg format. It's a variant of vitamin K which can be given in oral format.
So how do we use it? Is it used for 3 days or is it like a single dose? How is it?
No,
like?
if you want to give, at least give for 3 to 5 days.
Yeah. So it is 1 ampule IM intramuscular, right?
Yes.
But
Any role in
adult-
corticosteroids, doctor?
For itching?
For yes, and for intrahepatic cholestasis and itching, of course.
Look, I already said I've used rifampicin in my patient. Corticosteroids, it's really difficult to say. It's not proven to be of any benefit. What I always say is you are using calamine lotion. Trust me, I tell them to use every 2 hourly. This is the best solution which gives the patient a symptomatic relief on the burning sensation what the patient has. I tell them you can use 2 hourly, 3 hourly. The good thing I got to know that you can keep in the fridge and use it much better. Cold effect, that's something which is also something which is good. Ursodeoxycholic acid works nicely in 70% of a patient. Adding antihistaminics to those patients. Cholestyramine is a wishy-washy. Sometimes it works, sometimes doesn't work.
S-adenosine methionine.
I have used it, but again, personally, never found to be good. It could be as used an adjunct to your all other medications, but again, whether it's going to help you, some studies have shown it works, but I have not seen it to be using personally quite commonly in our patients in that point of view.
Can I make a small comment on UDCA? So UDCA or ursodeoxycholic acid, often patients are underdosed. So the recommended dose is 10 to 15 milligram per kg. So 300 milligram once a day or 150 milligram twice a day. That is often we come across such patients, and what we always do is upgrade the dose. We make it proper 15 milligram per kg, and then it does work. Like upgrading the dose.
What we have
does-
done,
do
not
give
even
a
15,
new
I've
dose.
gone to 20 milligram per kg body weight also sometimes.
Yeah, 20 to 30 milligram per
Yeah.
per
Yes,
kg
so
body
you can
weight
go
per
higher
day.
dose. So don't
We
worry
can
on the
go
dose
higher.
because there's no ceiling effect for this medication.
Yes.
So should we wean it when we are stopping the medicine? Like I generally prefer 300 milligram twice, but then we are scared to stop it completely. Should we say make it OD dose and then stop?
No, Dr. Kranti, your voice is really not audible. So I could just keep
What
you want to stop,
Dr.
how to stop
Deepak,
it.
what she is asking is when we stop the medication, that is, should we wean it and stop it, or we can stop it?
The question answers, when do you want to stop? Post
No,
delivery.
not how to stop. How to stop? Gradually
Post-delivery,
wean
if you
it.
ask me, the treatment of ICP is delivery. If you deliver the baby out, the symptoms will reduce drastically in these cases. So you can continue for at the most 2 weeks if the patient is symptomatic, or at the most 4 weeks maximum. Beyond that thing, you can just stop it suddenly. You don't have to gradually bring it down, because you have to understand the bile acids will go down drastically after delivery. And we are not worried about the side effects of the baby now after the delivery or the mother, because if any itching is there, symptomatic relief with the antihistaminics works nicely in those cases then.
Okay, sir. So can we move on to the next case? Second, gravida to para-1 living one with 31 plus weeks with twin gestation, presented with itching all over the body, especially hands and legs. And her last pregnancy also she had similar complaints of itching. And now she has grade 2 edema, albumin phase, blood pressure of 130/90. Everything is like borderline. Now, this time she has tried all homemade remedies and of course ursodeoxycholic acid. But now there is mild relief. In double digits, all of parameters, liver function tests are marginally raised. Now, Mude ma'am, would you manage the patient? Would you send her to a dermatologist, physician, or gastroenterologist? How would you go about it?
With the liver function test marginally raised, probably, I would rather refer her to a dermatologist.
So if it's less than 50 or around 50 to 70, that is what we call marginally raised. Is it right?
Yes. But what about her bile acids? Is it in triple digit or double digit?
No. It is less than 19 definitely. So hepatologist reference. So if it is severe ICP or early onset, or maybe first we try the first line, and in case we think she's still having persistent itching, definitely we would be referring her. whether the underlying liver disease is there, elevated liver enzymes, elevated INR. How high should they be when we refer to UTR? Because now she's a case of twin
So is
gestation
it
with borderline CIS.
is it
She
the
has also
ALT/AST or only the bile acids or all the liver? Because see, other tests are really not very significant, right? PT, INR, and all these things. What about them?
now she is a twin with a high risk for developing gestational hypertension, already albuminuria.
So you mean to suggest HELP syndrome? What about her
whether
hemolysis
she
or
is
anything?
right now nothing. She's all borderline. But now should
What
she
about her
involve the
platelets?
It's all. It can be even gestational thrombocytopenia, maybe.
So
this,
what is your diagnosis?
So such cases with an additional comorbidity or an additional obstetric factor should be involving the physician right from the beginning, because they can track the basic level and how we have guidance.
Yeah, because
And,
this is a
with
very
the body-
atypical presentation, what you are suggesting.
We have this very commonly in
Yes.
the municipal hospitals where there are.
Does she have any
Yes,
obstructive pathology?
Right now, nothing.
Okay. I would
Except
rather,
the
yeah, the multidisciplinary approach is always better, no? If we are confused, let us involve the hepatologist and the physicians
So if she
and
has
the
history of
skin.
cholesterol,
Pardon? You're not really audible, Kranti.
Dr. Deepak sir, if she had gallstones present, would the management change?
If the gallstones are present, now you have to do an ultrasound whether the gallstones are causing any obstructive symptoms to cause those liver enzymes derangement. If the gallstones are there, if they're symptomatic, then only our treatment is going to change. The most of the times we try to conserve. You have to understand that's the basic thing in pregnancy. Conservation is the basic thing. We don't want to intervene because we don't want to have anything which is out of the blue, which is coming to the pregnant patient and causing some, very rarely, even if it's there, any damage in that point of view. If the gallstones are there, if they are symptomatic, then you have to go inside. There's no option that point of view. But they are asymptomatic, we can wait and watch.
We are conserving the pregnancy now. When would we call for delivery, ma'am? Mujhe, ma'am, in case.
So that's what I'm asking. What about, is she going towards HELP? What is her, does she have low platelets?
Yeah, these are the conditions that in case of maternal or fetal conditions.
And we have to also do the fetal monitoring, her ultrasound monitoring, the color Doppler tests. All these things we have to take into account and see the maximum maturity where we can achieve the delivery and call for delivery.
So with associated multi-fetal gestation,
has,
there will be a restriction, oligohydramnios, high chances of going into pre-eclampsia, and with this we should be calling for delivery at an earlier gestational age.
Yes.
Case 3, ma'am. We go to this for you, Mrs. XYZ, para 1 living 1, day 3 of emergency section done for pre-eclampsia, blood pressure of 140/90 on 3rd day. She is complaining of itching. What would you do now?
Did she have any abnormal liver function tests? Did we do it first of all? Did you do her liver function
test?
Not
evaluated. Never. Now she is complaining of itching because mild itching just started transiently before delivery, and she was relieved.
Was it drug induced?
No, nothing.
Have you ruled out whether it was drug induced or not?
As for the oral antibiotics that she might be taking, if there is hypersensitivity, we would still take care of that after the test dose or what. But now she is still having itching because the blood pressure was borderline transient hypertension.
Transient blood pressure, transient rise, why should it cause itching?
Sorry, ma'am, she's pre-eclampsia.
Okay. So in pre-eclampsia, do we get itching? Not so often.
No, this is associated itching in pregnancy along with pre-eclampsia.
Oh, okay.
That is why when would we do the liver function test and how frequently post-delivery?
I mean, if there is, of course we do. In fact, liver function test, as Dr. Rohan had suggested earlier, to start with as a routine ANC profile, how many times we do it? We don't do it. And now she has delivered her baby just 3 days post-delivery, and she has started itching. So what are the other causes we have to rule out? I mean, whether it is drug-induced or whether there is any other skin, urticaria or any other skin ailment involved. And we should also repeat the liver function test if it was not done that time. So we can rule out if there is any liver pathology.
Yeah, thank you, ma'am. In case now she had liver cholestasis, intrahepatic cholestasis earlier, and now she has delivered. So postpartum management would be how, Dr. Deepak sir?
So you've already given the medicines for ICP. Post-delivery, I already said, you can continue for 4 weeks at the most. In 4 weeks, we expect it to turn out to normal because we have to do a liver function test in such patient to document whether they are touched back to normal or not. Because if they are not touched back to normal, you have to think of underlying disorders which is we have missed out. Nowadays, we have seen quite common NASH as the prominent feature, non-alcoholic fatty liver disease, which we see patients LFT doesn't turn back to normal. So we have to think of an underlying liver disease in these cases. So at least 4 to 6 weeks, you have a routine follow-up, do a liver function test at the end of 4 to 6 weeks. If it turns normal, your diagnosis can confirm also. You don't require anything else. And again, if it's still abnormal, better to do a further evaluation with the hepatologist.
If she is at the time of discharge, she is relieved with ursodeoxycholic acid and antihistamine. Should we discharge her and do on a OPD basis, follow-up basis, the liver function to return to normal? Can she be discharged?
In-house LFT is to be repeated. If the liver function test has been done before your delivery, if you have a diagnosis, you can just give a trend of liver function test. You cannot give a proper idea because the liver function test may take at least 2 to 4 weeks to come back to normal. So it may not be an adequate. If it's very margin elevation, you can wait. But if it's very high, suppose in the range of 200, 300, you can give an idea it's coming down. That's what we can do. But if it's just 60, 70, you don't have to repeat it. That's why it's on individual basis. You take a call whether liver function needs to be repeated before discharge or not. Ideally, what happens if we send the patient home? Medico-legally, we just do a liver function test just to be on the safer side that the liver function tests are showing a downward trend and the patient is being discharged now. It should not happen that after 2 weeks, the enzymes have again shot up some other reason. So that's where medico-legally you will be safe. That's what I can think of.
True that. So to sum up, the definition of intrahepatic cholestasis of pregnancy, the diagnosis should be considered in antenatal women who complain of itching and skin, itching on the skin. Total bile acid is more than 19 micromole per liter. And in post-delivery patients, if for 4 weeks after birth also, there is no resolution of itching, the liver function test coming back to normal means it was intrahepatic cholestasis of pregnancy. The consensus is now that the diagnosis of ICP requires elevated maternal bile acid concentration, and that women and pregnant people with itching and isolated raised liver function test with normal bile acid concentration should not be given a diagnosis of ICP. This is as per the Green Cross. If the bile acids are normal, then we should not label them as ICP.
Yeah. So, Dr. Deepak, here I have a question. So you said progesterone will increase the, like what you say, intrahepatic cholestasis and patient has itching. And so you ask us to stop the progesterone and so what is the best form of progesterone which will, like we have intravascular depot injections. Sometimes we have to give these patients, they are on cerclage or to prevention of preterm labor, or sometimes they come with IVF conception. So they may be on dydrogesterone, they may be on micronized progesterone or intravascular progesterone. So which is the best form? Ideally, as you said, all will cause, but if required, how should we give them? And
first of all, sorry, I have no idea about the microprogesterone. But again, whatever, if it's a strong indication to give progesterone, even if you have a deranged liver function test, I still advise if you want a strong indication, you can continue. We have discussed many times if you have a strong indication where you want to continue the pregnancy because of the for the continuation of pregnancy, for the safety of pregnancy, you can give progesterone. Try to give as minimal dose as possible, whichever format you want to give. Oral, I won't prefer Depot. That's the only thing which I don't advise because Depot takes a longer time to clear from the body. As simple as that. When we use a smaller dose, single dose, we can stop it. If your liver function tests are monitored serially, we can stop it if required. But if you give a Depot progesterone preparation, it may take longer time for the body to clear off. So Depot is the one which I'll try to avoid. But again, yes, you can use a lower dose if possible, if you want to continue with serial monitoring of liver function test. You have to understand it's not straight and forward. We have to see that progesterone is not a dose dependent effect. It's more of a iatrogenic effect. If you get an effect, deranged liver function, it will be seen on first dose also. It can be seen any time of the time. It's not like a dose. You have to increase the dose. It may worsen sometimes. That's what we always say. Try to have a serial monitoring of liver function test. If it's indicated obstetrician point of view, please continue. I always says there are certain cutoffs which we can take a call. Enzymes going to even 200, 300, we can still manage somehow on that point of view. But again, if it's really an obstetric indication, then only we have to take a call. Certain parameters which goes haywire, suppose the INR goes very high, more than 1.5, 1.8, then I'm skeptical, because that's the first thing which I'm thinking of. Anything else, that's why we have to think of other condition, like HELP is there, AFLP is coming to picture. Then we have to stop all those medications. That's why indications from your side and my side also is important. So depending on that point of view, it's not like I don't stop that. I always tell, ask your gynecologist, ask your obstetrician whether she wants to continue the progesterone supplements or not. That's what I advise to my patient when he comes to me. If they can be stopped, much better for me, because I have already have pregnancy as one of the point, into adding progesterone will have an additional effect on that point. It may be not 1+1, but it will be some synergistic effect will be there. So if it will be your call to take a call on progesterone effects. But as we already said, lots of patients on IVF, we have given lots of hyperstimulation with all the hormonal treatment. That's why I take a call with the obstetrician whether she really wants to continue, because there may be some special condition where the patient is a very rare pregnancy, special pregnancy. We have to take all the risk and benefit into consideration, then go ahead.
Thank you, Dr. Deepak.
Can I ask one just query? There is a marker which is recently sort of developed, which is glutathione transferase alpha, which is a marker which will decide about the cholestasis about 8 to 9 weeks earlier than it can actually happen.
There are two markers, if you ask me. One of this we have said, and I think there's one more called autotoxin or something like that.
Okay.
These are all, we don't have any, in our India, at least we don't have it with us. That's the first thing. Second, even if it's there, we need proper documentation, proper studies on that point of view. Even if we detect 8 to 9 weeks early, are we going to treat the patient? That's what we always say. Even if you have ICP,
see, because the bile acids have not yet risen. It's only the marker which is present.
If the patient is asymptomatic, there's no pruritus, nothing is there. What are we trying to treat?
Yes.
UDCA will work in symptoms, not for the bile acids, not for anything else. That's what I'll say. Even if your markers goes high, the bile acid may go slower. You are just replacing the bile acid with the ursodeoxycholic acid. It's just a matter with the symptoms are going to get treated. That's what we always say. If the symptoms are there, if you get a bile acids, much better. If the symptoms are not there, even if you get a high markers of those alternate markers, they can give you an idea that the patient will develop ICP in future also. You should be prepared by doing bile acids in those patients more frequently then.
Thank you, sir. Can we just have rapid fire to conclude? Deepak sir, bile acid concentrations are not associated with itching, intensity of itching. True or false? Am I audible?
It's for me or everyone? That's what I like to know.
So the liver function test.
1 minute, I'll just take a leave.
Or aspartate transaminase are associated with negative pregnancy outcome.
No.
No, false. Well, bile acid level is the strongest predictor of fetal risk. You have just enlightened us.
Yeah, as per the studies, it is the only thing which is being given a fetal risk values, which we say.
And vitamin K injection is unnecessary in intrahepatic cholestasis unless she is
not unnecessary. Well, and as and when indicated, you should give it.
Yeah. So it is a conditional, and cholestyramine is an adjunct advised to all obese women with intrahepatic cholestasis because it reduces the level of cholesterol in the blood. Is this true?
Yes, cholestyramine has a multiple effects. It reduces cholesterol, but whether you are going to use for reducing the cholesterol, I don't think so. Yes, for symptoms, I will use it.
Yeah, so as an adjunct, it is true. The latter half is not true. Okay, thank you all for contributing so much to our knowledge. And sorry for the internet glitches. Thank you for the opportunity.
So their question was the
I'm looking
vaginal
more
progesterone
forward.
can be used. I said, I'm not the expert. You are the expert in using the progesterones. I just tell them use as minimal dose as possible, whichever format, but serial monitoring of liver function test is required.
Okay. Thank you, sir. Thank you, ma'am.
I would like to thank Dr. Deepak, Dr. Rohan, and the students, Dr. Leena, Dr. Gayatri, and Dr. Kranti for moderating the session, and Mude Madam for being an expert. Thank you. Thank you all. That was a very enlightening discussion on many points. So we need not worry too much about the intrahepatic cholestasis. So that is what people, when they have that thing, intrahepatic cholestasis, they say you will have to terminate 37 weeks. Now that is gone. So even with mild in ICP, you can take it up to term. That is what the take home message. Yes, ma'am. Would you like to end the session with any comments, Dr. Mude?
Not really. I mean, ICT has become a very common thing. And basically, post-delivery, these patients should not be given OC pills as the contraceptive advice. You know, they can go for intrauterine contraceptive device, but not OC pills.
Yeah. Thank you. Thank you for the wonderful session. Thank you all. Thank you.
Thank you, sir. Thank you.
Thank you, madam. Yeah.